Thanks very much, Alan, and thanks everyone for attending this session. So, I'm going to be talking about glutamate in psychosis and depression. One of the key things to talk about in this session is NMDA receptors. These are glutamate receptors which are involved in a number of different brain functions, including memory and neuroplasticity. They're voltage-gated ion channels that have a intrachannel site that can be blocked by ketamine or by other compounds like PCP. So ketamine is an interesting compound. It's an anesthetic agent, and at sub-anesthetic doses, it can cause changes in perceptions, including delusions and perceptual distortions. It can also cause effects resembling the negative symptoms of schizophrenia. And for this reason, there was a lot of interest. There's a lot of interest in ketamine and its effects because of these effects that look like schizophrenia. And this, in part, led to the NMDA receptor dysfunction hypothesis of psychosis. So this is work from Olney and Farber from 1995. They were looking at NMDA receptor antagonists like ketamine and showed that they caused toxic changes in the brain. And they showed they could also block these effects by blocking AMPA receptors. They thought that this was due to there being excess glutamate release caused by the ketamine, and this could be driving the toxicity. And they thought that maybe changes in the brain in schizophrenia, the changes in brain volume could have a similar underlying basis. So this is the way they thought this might work. So we have GABAergic inhibitory neurons, which provide inhibitory control over the glutamate projection neurons, expressing NMDA receptors. Ketamine blocks these and blocks the inhibitory tone, leading to increased glutamate. So this was the theory, and is there any evidence for this going on actually in schizophrenia, and how does it relate to symptoms? So we did some work using a spec tracer called CNS1261. This is an NMDA receptor binding tracer that binds to this intrachannel site, which is the same site as ketamine. You get brain images like this, because NMDA receptors are expressed throughout the brain. And we use this to look at people with schizophrenia who are unmedicated, found that they had reduced binding in the left hippocampus. So this is shown here in drug-free patients with schizophrenia compared to healthy volunteers. This was closely mapped onto post-mortem data that was published previously from Bill Deakin's lab in 2001, where they showed that there was reduced mRNA for NMDA receptors in the same brain region, particularly on the left side. We've gone on to repeat this work using a PET tracer, 18F GE179, and we looked again at patients with schizophrenia compared to healthy controls, and we've just recently published this that we again found reduced NMDA receptor binding in the hippocampus. So, next question, is there evidence for increased cortical glutamate in patients with schizophrenia? So, to look at this, we used a technique called proton magnetic resonance spectroscopy, which is using a standard MRI scanner, and you get an output of a spectrum. Some of these peaks correspond to different chemicals, this one being glutamate and glutamine. Previous work had shown that in first episode psychosis, unmedicated, there was increased levels of glutamine in the anterior cingulate, and we repeated this again in patients, in people who are at high risk of developing psychosis because they had an at-risk mental state, and these people also had elevated glutamine levels in anterior cingulate. There's some suggestion that this might happen early on in the illness. This meta-analysis from some years ago now suggested that higher levels of glutamate and glutamine in the frontal cortex were present in people with schizophrenia, but only in the early phases of the illness, so between the ages of 20 and 30. So, moving on, could brain chemistry predict response to antipsychotic agents? So, seeing these changes in glutamate and knowing that some people don't respond well to conventional dopaminergic antipsychotics led us to suggest that this non-response might be due to there being a different underlying biological basis to these patients who had a poor response to antipsychotics. And we looked at this again using magnetic resonance spectroscopy, again in first episode Psychosis. So looked at people 1 year after they had treatment with antipsychotics and showed that people who hadn't responded well tended to have higher levels of glutamate in the anterior cingulate cortex. Higher the levels seem to correlate with more negative symptoms and lower global functioning. Went on to do this again using a combination of magnetic resonance spectroscopy and 18F-DOPA, and found again that people who were poor responders to antipsychotics tended to have higher levels of glutamate in the anterior cingulate, but that they had normal levels of F-DOPA uptake, whereas people who were good responders to conventional antipsychotics had normal levels of glutamate, but had elevated levels of 18F-DOPA, suggesting that there could be these two different populations, one with more dopaminergic abnormality and one with more glutamatergic. Again, further study that found the same thing. And then more recently, we did the study Strata, where we looked at 18F-DOPA and glutamate in people with first episode psychosis. But in this study, we didn't find such a strong finding. There was still some elevated levels of glutamate, although not as strong as previously seen. No differences in glutamate or striatal or striatal dopamine uptake. So this suggests that there could be a good target for antipsychotic drugs, looking at the glutamatergic system in schizophrenia. So how does this work out? There's potential different targets for this. So this is the GABAergic interneuron providing inhibitory tone onto a pyramidal cell. So you could potentially enhance NMDA receptor activation here. You could enhance the dopamine, the GABA activation here at the alpha-2 receptor containing GABA receptors, or you could try and activate glutamate release downstream, maybe by blocking this autoreceptor mGlu23. So those are the three. So how did this work out? So bitopertin came forward as a glycine T1 inhibitor. So this is basically acting around here, trying to increase activity at these NMDA receptors. And it looked very good in phase 2 studies, but unfortunately phase 3 did not separate from placebo. There was a very strong placebo effect, and there was no greater improvement with bitopertin. Then prior to that, there's also been these two compounds, pomaglumitad, which were developed by Lilly, which were mGlu23 agonists. And these, again, didn't show any difference from placebo. But when there was a subsequent post hoc analysis, it looked like people with early psychosis, so first episode, might have done better with this compound. So it's possible that if it was targeted to these particular subtype of patients who are in the early stages of psychosis, that it could have worked better. Also just wanted to put this slide here about sodium nitroprusside, which also potentially works via a glutamatergic mechanism. There's very exciting preliminary data suggesting that it had a very profound effect on psychotic symptoms in people with schizophrenia. We tried to repeat it and found that there was no difference from placebo. Again, you can see that in the original study, the placebo group didn't seem to have any response at all to sodium nitroprusside, which is a bit surprising. Whereas when we repeated it, we had an effect in the placebo group, and there was no difference between the two. So for the second bit, I just want to talk very briefly about brain glutamate in depression. There's been a few studies now looking at brain glutamate in the anterior cingulate in depression. This is a meta-analysis from 2011, and then a more recent one from 2019, showing that in anterior cingulate frontal cortex, people with depression tend to have lower levels of glutamate. So this could potentially be a target for ketamine, because obviously blocking the NMDA receptor could lead to increased glutamate release. This has been shown in humans. Study from Laura Rowland in 2005 showed increases in glutamine following ketamine infusion. And then study that I did following that, showing again that ketamine led to increases in glutamate in the anterior cingulate cortex. So how does this work out? So we have the data from Carlos Zarate about ketamine. So ketamine actually seems to have a very nice antidepressant effect that's prolonged. We're going to be talking a bit more about this tomorrow. S-ketamine also shows a nice effect on reducing depressive symptoms in people with depression. However, rapastanel, which looked very promising, NMDA receptor glycine site positive modulator, but which had ketamine-like effects in terms of antidepressant properties. Very promising preclinical studies. Phase 2 showed good efficacy. Phase 3 failed to separate from placebo, and so further studies were stopped. So in conclusion, there's growing evidence that glutamatergic neurotransmissions altered in schizophrenia and also in depression might be a potential target for both antipsychotic drugs and antidepressants. But to date, ketamine is the only glutamatergic drug that shows any clinical efficacy in patients with depression. And there are no glutamatergic drugs effective in schizophrenia, although there's some suggestion that targeting patients earlier in the illness could lead to better outcomes. So the last point I wanted to make is that placebo responses are leading to multiple drug failures in depression and schizophrenia. And these are my acknowledgements. Thanks for your attention.